with major resective surgery. And an important question is going to be whether we can stratify patients according to risk, so that within these groups of patients with liver resection, there may be some at higher or lower than average risk where we might be more or less aggressive with chemoprophylaxis. So for instance, you've shown some clinical factors, including the length of time of the surgery and the extent of hepatectomy, that seem to place the patient in higher risk categories, and they might be criteria we would use to be more aggressive with chemoprophylaxis. And I'm wondering if you would consider the development of perhaps other biochemical predictors of VTE risk. We've shown recently, for instance, in pancreatectomy patients that platelet factor 4 is a strong predictor of postoperative VTE events, and wonder whether this could be applied in the hepatectomy population. But thank you for a very nice presentation.
Thanks, Dr. Mulvihill. As to the first question, we knew this would be something that came up in terms of the 30-day DVT prophylaxis. One major limitation of all NSQIP studies is that it lacks the granular data to know whether people were initiated on DVT prophylaxis and on what day. But I think that this is our current practice right now. In the past, we didn't necessarily put people on DVT prophylaxis, but we do put people on DVT prophylaxis in the form of sub-Q heparin for major and minor hepatectomies unless their INR is significantly elevated above 1.8. And you can see these are our own personal DVT and PE rates. But this is a study from 2002 for comparing people who just get DVT prophylaxis during their hospitalization, for about 1 week or so, versus getting it for 21 more days. And you can see that it does decrease the 30-day VTE rate and even a 90-day VTE rate. So there are, and these are for high-risk surgical oncology patients. So the issue is, what do you consider high risk? Not every surgical oncology patient is the same. So for our pancreas practice, for example, we do send people home on DVT prophylaxis for a month after surgery. So that's something I think that we need to talk about. But in reality, I think the reason we're even discussing this paper is because we want to introduce and open some eyes that VTEs do actually happen in liver surgery. And I think this is probably the national practice where if you have a greater extent of hepatectomy, you probably are less likely to be on DVT prophylaxis after surgery. Obviously, we don't know the slope of this line, but this is just showing, and that might be contributing to why extended hepatectomies have more VTE. Ideally, we get to the point where we get to some kind of goal. It'll never be 100% because there are certain patients, as Dr. Mulvihill is referring to, based on risk factors that won't get VTE prophylaxis, and hopefully in the future with molecular markers pre-op, we'll know who will be at greater risk to be more aggressive about VTE chemoprophylaxis.
Dr. Yo.
Thank you very much. I enjoyed your talk very much, and I agree largely with your recommendations regarding standard of care. I think there's another element of this, and that's also the use of antiplatelet agents in complex general surgery. I know your study was not designed to look at that, but we're learning more and more about that, and certainly the old adage, similar to hepatectomy, the old adage there was that you should stop patients' preoperative antiplatelet agents before major surgical resection, and I think many of us are finding that that's not true, and there's some emerging data. I want to just point out two comments about your trial, and I think you've answered one already, and that is you don't really prove in your trial that the use of chemoprophylaxis using the limited NSQIP data, which I think NSQIP is wonderful. I'm not in all targeting NSQIP, but you can't prove per se from this study that chemoprophylaxis against DVT is successful based upon your data. So that's a comment. The question is, VTE can have many different components. Oftentimes, patients undergoing major hepatectomy get central lines and cordis catheters put in, and my question is, were you able to stratify out true deep venous thrombosis, typically in leg veins, from what many people think is innocuous central venous thrombosis or an arm swelling? And so I think you understand the question. Is this true DVT, or could this be a VTE related to a central line? Thank you.
Thank you. That's a good point. That's the one major downside of the NSQIP database, again, is that we can't know whether it's central line related or if it's from the operation itself or the postoperative course. But I think that people in some places are moving away from central lines, for example, at our institution. Looking at it, breaking it up, there's a 2.9% rate of VTE, of which 1.8% were DVTs and 1.3% were PEs, and that adds up to 3.1. I know it's slightly higher because some people had concomitantly both. And then the comment about aspirin is a good point, and it's something, for example, in pancreas surgery used if you have vein resection. And I think people are moving toward allowing more use of aspirin as we improve our surgical technique.
Dr. Strasberg.
I also enjoyed your talk. Congratulations. We recently used NSQIP data to try to evaluate a way of quantifying postoperative complications that we call the postoperative morbidity index. And one of the operations we looked at was right hepatectomy. We had approximately 100 right hepatectomies to look at. Interestingly, when right hepatectomy was combined with another procedure, two additional procedures we looked at, hepatocojejunectomy, for instance, in patients who had cholangiocarcinoma, or colon resections, the postoperative morbidity index tripled. So have you had an opportunity to look at this potentially additional factor to liver resections to see whether adding a second procedure increases the chance of having venous thromboembolism?
Thank you for your comment. I'm familiar with your paper, and in this database, we did look at concurrent procedures, and concurrent procedures were significant on univariate analysis, but not on multivariate analysis for predicting these complications. And in terms of our current practice, for example, if we do a simultaneous colorectal operation with the liver, a lot of those colorectal patients will actually get on-table heparin for their pelvic operation, and then we do the liver resection at the same time, and we continue the DVT prophylaxis, and these people seem to do well.
Professor De Santibanez.
Yes, congratulations. I really enjoyed very much your paper and I learned a lot. For a practical point of view, what is your advice when to start with a chemoprophylaxis after a major hepatectomy if the patient has maybe most of the patient has some postoperative liver failure? What is your advice? When to start?
So standardly, right now, as we're not using intra-op heparin yet, but post-operatively on post-op day 1, if the INR is less than or equal to 1.8, so we do check the coags the next morning just to make sure they're not in severe liver insufficiency. Then we would start subcutaneous heparin. We use heparin instead of Lovenox currently, maybe just so that we can stop it more quickly if we have to. But we do that standardly. It's already on our order set. It's already ordered. In fact, that's the default, and only we would stop it if something was wrong with the lab.
Dr. Pitt.
Henry Pitt, Indiana. Again, very nice study. As we all know, in the United States, the government is forcing us to do more and more things that they believe are correct, and VTE prophylaxis has become one of the SQIP measures over the last 5 years, and nationally, more than 97% of our patients are getting VTE prophylaxis, and nowadays, if you don't get to 99.5%, they're going to take money away. So with all of that background, my guess is a lot of us are giving a lot more prophylaxis than we used to, and I'd like to take a little poll of the audience. Now in 2012, if your patient has an INR that's reasonable on post-op day 1 after a major hepatectomy, how many are actually giving VTE prophylaxis? So I think there's probably been a big change over the last 5 years, but very nice.
Yeah, I agree. Thank you.
Elijah Stewart, San Francisco. I just had a couple of questions. First of all, did you look at the presence of cirrhosis in your group? I didn't see it in your multivariate analysis. Did you look at that? What is a bleeding disorder? Did you look at platelet count? And then thirdly, what about laparoscopic hepatectomy? Why did you exclude those and focus on the open? Do you think how would you think that would change your data?
Thank you. We didn't have cirrhosis, but we analyzed ascites, and it was not in the multivariate analysis. In terms of bleeding disorder, definition includes people already on anticoagulation or a known bleeding disorder. Aspirin is not counted if you're on aspirin, just for cardiac reasons. We excluded laparoscopic and we excluded emergent because those are two different things. We wanted just to focus on the narrowest type of patient possible to make sure it's just as clean as possible. We especially exclude the emergent cases because that just messes up everything because those patients have extremely high morbidity, such as trauma cases.
One question.
Thank you. Emily Winslow from University of Wisconsin. I think, as you can tell from the number of comments, this is a really important topic, so I really appreciate your presentation. The one concern I have is the capturing of rates of post-hepatectomy hemorrhage in the NSQIP data set. So, as you know, the definition only includes patients that have received more than 5 or more units of blood within 72 hours post-operatively. Any patient receiving less blood than that, having a bleeding complication without transfusion or receiving blood after that point isn't counted. And since this is the International Study Group classification of post-hepatectomy hemorrhage includes all of these patients, I'm wondering what fraction of bleeding events do you really think you've captured? And to conclude that the VTE rate is so much higher than hemorrhagic events from this data set, I'm wondering if you think that's a fair conclusion.
Yeah, that's a good point. I think the original definition for the entry system was for greater than or equal to 4 units of packed red blood cells. However, the more recent definition in the dictionary is to record, for the research nurses to record any transfusion in the postoperative period. So it's actually changed over time. We analyzed subsets of our data up to 2007, for example, and then looked at 2008 with the changes of definitions, and there was no difference in the overall rate of VTE and bleeding events. And you're right, though, it's still going to probably miss some things, but this is more to open our eyes and look at VTE is significant, and bleeding events are dependent also clinically on your own institution, your own surgical technique, but it's just something to think about, balancing the risk of one versus the other.
Professor Belghiti.
Yeah. Again, congratulations to destroy this old concept. I just have one question. Have you any idea or any thought what is the reason of hypercoagulation after major hepatectomy? Because that was your show.
Right. Unfortunately, we can't analyze any molecular factors. If I had to personally theorize, there might be 2 things. Manipulation of the IVC is one thing. But then also, practically speaking, it goes back to that graph I drew of the slope going downward. People with larger magnitude of hepatectomy might be less likely to be on DVT prophylaxis after surgery because, as you might expect, extended hepatectomy, people are more scared of having bleeding, so they may withhold the VTE prophylaxis and may withhold it for several days, even after the INR has corrected itself. While if you just have a partial hepatectomy, these patients may be automatically, routinely put on DVT prophylaxis, and so that might be a practical reason why extended hepatectomies are more likely to have VTE.
Dr. Adams.
Very nice paper. Great discussion. There have been a couple comments about timing. In our own practice for about the past decade, we have given it at the time of surgery, and there's no difference in bleeding. So I don't think whether you give it on the operating table like we typically do for cases or whether you wait for the first postoperative day changes your bleeding risk in that patient population. And we give it pretty much across the board, except in the few cases where you have an elevated INR or you think your bleeding risk is going to be particularly high. And that's particularly important now with the, being able to measure your future liver remnant and understanding who may or may not be significantly coagulopathic postoperatively.
Thank you.
One more.
I would like to ask you, congratulations. We give heparin on the operative table, but we are not allowed to use epidural because anesthesia is very concerned about possible bleeding. So in your institution, what do you do for that? Do you use epidural or how do you manage that?
Yeah, we do use epidurals a lot, far more than I saw in residency here now in fellowship, because every anesthesiologist routinely does it. So unless there's some other major problem, 80% of our major hepatectomies get epidurals, and they have no problem. So here you can see in preoperatively we don't give heparin, but let's say for pancreas surgery or colorectal surgery, our anesthesiologists have no problem giving heparin after they place the epidural. They don't give the heparin before the epidural, but after they put the epidural and everything's fine, they'll give it before we start the operation.
Dr. Tzng, thank you.